laying the groundwork for physician integration. You know, it's interesting with ACOs, accountable care organizations, getting a lot of attention, bundled payments getting a lot of attention. There's no doubt that physician partnership with the hospital is going to be paramount. Well, you know what? We've been sort of looking at that for a long time. In fact, I've gotten a real charge of these last year with ACOs as all of a sudden, you know, hospitals and physicians are talking about getting married, or at least one wants to marry the other one because they want to make sure, and well done, well so, they're prepared for bundle payments, demonstration models, and things like that. In fact, I was going to write this article instead of physician integration. It was going to be called, gee, I didn't like dating you, so why are we getting married? Because over the years, most organizations, I will say, have inconsistent relationships with physicians. So all of a sudden now, at a crucial time, we want to say to physicians, let's integrate, let's become partners. Now, we know strategically that makes a lot of sense. We know from a payment system that we're going to be pushed that way. So I'm not saying the goal is wrong, but how can we smooth out the transition to get there? Because if we have mistrust, if we have lack of confidence in each other, we won't get there. Or if we do get there, it's going to be very painful. And none of us want to go through more pain than we already do being in an ever-changing healthcare reimbursement environment. So let me talk about some tips on physicians. First one we wrote years ago was called Focus, Fix, and Follow-up. One of the things we find when we look at physician and their perception of the hospital or their trust is, are you hearing what I'm saying? Are you fixing what I'm asking you to fix? And follow-up. In fact, one of the biggest indicators of dissatisfaction with the medical staff is lack of administrative follow-up. Now, we can try letters and do different things, but let me give you some real tips. Number one is measure physician satisfaction. You know, when a patient comes in to see a physician, the first thing the patient is going to have is a diagnosis. When we're looking at solving any problem anywhere, we do a diagnosis. Physicians are diagnosticians. So I'll go to hospitals or healthcare organizations who will say that they want to improve their relationship with their physicians. And I'll say, well, how is it right now? Well, most will say iffy, or it could be better, or it's pretty good, but I want to get it better. You know, it's always good. Everybody's sort of got a gut feel on it. But the problem is we don't have what I call the data. Now, we're going to sit here and we can talk to ourselves and say, yeah, but not everyone fills out a survey. Well, you know what? We look at HCAHPS and we look at massive changes. Not everyone fills out a survey. We look at employee satisfaction and we make changes based on the employee satisfaction survey. Not everyone fills out the survey. So one of my key points is, first of all, is to make sure you focus, is really measure. Measure physician satisfaction. By measuring physician satisfaction, you can have a baseline. It also allows you to create a diagnostic plan, which you should share with your medical staff. Because that's like you would share a plan with a patient if they had a diagnosis, what their MR looks like, or their CT or their labs. You'd create a treatment plan and do that with the physicians. Next is focus. And some of the various ways we can look at focusing is making sure that we pick one or two things that we're really going to nail. For example, at Advocate Good Samaritan in Downers Grove, Illinois, they really focused on central line infections. Other places will focus on things like moving patients through quickly. I was at a hospital at one time, and the biggest complaint by the physicians is they couldn't get beds. Patients couldn't get beds. What they did a study, and they found out if the discharge order was written by 10 o'clock that morning, they would free up a lot of beds. So the plan was, the focus was to make sure that we made it easier for physicians to write the discharge summary. And if we did, we'd have a lot of more freed up beds, which would help with flow. That was a plan that was focused. It was a collaborative plan. It made sense. My own story was, of course, decubitus. At the hospital, the physicians were complaining. So we really pushed this. We had scorecards and everything, but we got the win. Doctors understand